Hi everyone, it's Alexandra again from Power Adelaide, and we're here to talk about antihypertensives today. So high blood pressure increases the work of the heart and is associated with an increased risk of cardiovascular events such as stroke and MI, heart failure, and kidney failure. Patients' individual cardiovascular risk needs to be taken into account when deciding to start antihypertensive therapy. Generally, any blood pressure that's above 160/100 is treated, and that's regardless of their cardiovascular disease risk. There is a continuous relationship between the blood pressure and the cardiovascular risk. So different guidelines can have some variation in the cutoff values for the blood pressure categories. This table shows the classification of the blood pressure levels used by the Heart Foundation Australia with regards to starting antihypertensive therapy. High blood pressure is often asymptomatic, which means the patient may not even know that they have high blood pressure. If symptoms do occur, they can include early morning headaches, nosebleeds, irregular heart rhythms, vision changes, buzzing in the ears, severe hypertension. The patients might feel fatigued, quite nauseous. They might even be vomiting. Often they can be a bit confused or have high anxiety. They could have some associated chest pain and even some muscle tremors. Controlled blood pressure is associated with a reduced risk of stroke, reduced risk of coronary heart disease, chronic kidney disease, heart failure, and death. So all things that we definitely want. Benefits are achieved even with small reductions in blood pressure. So this webinar focuses on antihypertensive medications, but blood pressure needs to be treated in conjunction with an assessment of all their cardiovascular risk factors and also with diet and lifestyle modification. But today we're only going to be talking about the antihypertensives. So when we're using antihypertensives in patients, we are looking for a target blood pressure generally below 140 or 90. If we want a more aggressive target, which is below 120, this might be considered in a patient with a high cardiovascular risk. However, if we are going to treat them too well, decrease their blood pressure too much, then we may also put them at higher risk of side effects such as hypertension and syncope. So it's a bit of a balance. We need to make sure that we're managing them well, but not too well, that we're giving them too many side effects. So what kind of agents can we choose? These ones are listed on the slides. The most common ones are ACE, ARBs. Then we also have the calcium channel blockers and thiazides and the thiazide-like diuretics. The data seems to suggest that they all have a similar efficacy. So it's basically selecting the right drug for the right patient, and that can take a bit of trial and error sometimes. Some of the things which we might take into consider when looking at what blood pressure to start from, with which patient. We can look at what adverse effects we might be a little bit more wary of. If they have any other comorbidities, maybe some agents will have benefit in their comorbidities as well. So when we're looking at which ones to start, which agent to start in which patient, if we're talking about comorbidities, for example, the patient might have chronic kidney disease, we might look at the ACE or the ARBs. For heart failure, we know that there are specific drugs which do have beneficial effects for those patients. Especially some of the beta blockers are more favourable in heart failure than the other ones are. After an MI, the evidence for beta blockers and ACE inhibitors obviously is quite strong. We know from experience that using these drugs after MI will have long-term benefits for the patient. In angina, we have specific medications that we prefer to use for blood pressure, which is going to help with their have benefits in their angina as well. And for AF, obviously the same deal. Those are more like the cardiac comorbidities. When we're looking at other comorbidities such as asthma, COPD, we need to look at drugs which might not be so good in these patients. So for the asthma patients, COPD patients, we might think the beta blocker is not the greatest drug for them because it could potentially lead to exacerbation of their asthma symptoms. Patients with bradycardia or heart block, there are some drugs which we would like to avoid. Patients in heart failure, they're also drugs that we're looking to avoid. Obviously, we don't want to worsen their other conditions. And then gout, looking to avoid those thiazide diuretics there. So if we first talk about ACE inhibitors, so ACE inhibitors are enalapril, ramipril, the ones that ends with pril. We know that they are used quite commonly in hypertension. If we go through really quickly how they work, so they block the conversion of angiotensin 1 to angiotensin 2 and inhibit the breakdown of bradykinin. This reduces the effect of vasoconstriction, which is caused by the angiotensin 2, and reduce the sodium retention and the increase the aldosterone release. So these medications do have additional benefits in heart failure with a reduced ejection fraction and in patients with kidney disease, which is particularly in those diabetic neuropathy patients. It's good to know that we should not use these ones in the patients who have the bilateral renal artery stenosis, as they can actually increase the risk of renal failure. So we don't want to be doing that. With the exception of captopril, the ACE inhibitors are usually given as a daily dose, a single daily dose. The user dose range depends on the agent being used. Obviously, we want to start with a lower dose initially, especially if we're concerned about our elderly patients. Patients might have a significant first dose hypertension, patients who are already on high doses of diuretics, patients who are on dialysis, patients who may have a low sodium or low fluid intake imposed onto them. These are some of the typical doses for the ACE inhibitors. Obviously, captopril is used more often because of its shorter half-life. So we give that more frequently. And in like an ICU setting, it's preferred to use the drug captopril because we're going to have the effect much more quickly. And also, if we need to stop it, we'll be able to stop it a lot more quickly and to have that effect of stopping the drug obviously quite immediate, rather than waiting maybe a day or two for the effects of the other drugs to stop working. So common side effects of the ACE inhibitors. Obviously, a lot of them are relating to what we're doing, which is reducing the patient's blood pressure. So hypertension, headache, dizziness, increased potassium that we see with the ACEs, fatigue, nausea, some renal impairment. Some of that increased creatinine can be quite transient though when we're first starting it. So it's good to obviously reassess the patient's creatinine after 6 to 8 weeks of therapy to make sure that it wasn't just a transient increase in their creatinine. And the cough, which comes from that bradykinin cough, we'll just note there that it's not a life-threatening cough. It's just basically annoying for the patient. So it is important that they do tell their doctor if they are experiencing the cough, though, because it's something that we can fix by changing the agent. So with the increased risk of hyperkalemia with these ACE inhibitors, obviously it's not ideal for the patient to have hyperpotassium long term. This leads to renal impairment. Hyperpotassium obviously can increase the risk of a heart attack as well. So we need to look at these patients for worsening renal function, make sure any other medications which can also increase potassium are taken into consideration. Tell the patients not to take any potassium supplements unless they are advised to by the specialists. And also if they have any potassium in the salt, which they're using as well. An alternative to the ACE is the ARB, which are the drugs which ends in sartan, like valsartan, irbesartan, telmisartan, etc. So adverse effects quite related to what they do, which is reduce blood pressure. So dizziness, headache, and also they have that hyperkalemia component as well. These are usually only seen in daily dosing. Obviously, what happens in practice can be a little bit different, but generally we'll only see them in the daily dosing, once daily dosing. I'll just go back to that slide and just mention here that the sartans can be used as a replacement for the ACE inhibitor in those patients that do get a cough from the ACE. So what often will happen is if the patient notices a cough with the ACE, then the doctor might change them to the sartan and then notice that they don't have that cough. Okay. So calcium channel blockers. We have dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. So the first line agents would be the dihydropyridine calcium channel blockers, and these ones are amlodipine, felodipine, levodopa, nifedipine. These ones may be used once or twice daily. Often they reduce also, as well as the blood pressure, peripheral vascular resistance and blood pressure by vasodilation of the peripheral arteries selectively. Non-dihydropyridine calcium channel blockers, which is the verapamil and diltiazem, are not first line in hypertension because they show less peripheral vasodilation selectively than the dihydropyridine ones. So they can be thought as cardiac selective calcium channel blockers, which reduce heart rate and contractility. And verapamil does this a bit more than the diltiazem as well. So when we look at them in the table, we see the ones that we mentioned, the dihydropyridine versus the non-dihydropyridine. It's important to note that in the dihydropyridines, most of them are daily, but we need to be aware that the nifedipine, depending on the formulation, can be used either daily or split dosing throughout the day. And then with the dihydropyridine ones, we have the same thing, where the controlled release would be used daily, but with immediate release, we need to be using that more frequently. And this is really important, especially with the recent shortages in stock. We've seen a lot of patients going from the SR verapamil to the IR. And so where we can intervene as pharmacists is to make sure that the prescribers are increasing the frequency of that, because obviously we don't want the patients to be on IR verapamil daily. It's not going to give them the same results as the SR. Common side effects from the CCBs include these ones listed on the slide. Peripheral edema is more commonly with dihydropyridines. It's not related to fluid retention. It's just a redistribution of extracellular fluid. So it doesn't respond to diuretics. So you can't just give someone like furosemide to get rid of the peripheral edema from like amlodipine. You need to attend to the drug which is causing the side effect, not try and give the diuretic to get rid of the fluid, because it's just not going to work. Next drug is the thiazide and thiazide-like diuretics. These ones inhibit the reabsorption of sodium and chloride in the kidneys. Therefore, we have an increase in the potassium excretion. They're only moderately potent. So lowering of blood pressure is thought mainly to occur by vasodilation when they're used at the low doses. The 1.5 controlled release indapamide tablet has a similar antihypertensive efficacy to the 2.5 immediate release tablet, but the benefit of it being in using the 1.5 controlled release is that it's got a lower risk of hypokalemia. So this might be taken into consideration with the other patients' comorbidities. When we're looking at the loop diuretics, like furosemide, they're not really recommended for the treatment of hypertension unless the patient's fluid overloaded. So we're not only using the thiazides and the thiazide-like diuretics shown in this table for those. Moving on to combination therapy now. So there are effective combination therapies. We can use two different or multiple different agents if the patient hasn't tolerated the initial drug, or if the patient doesn't reach their target blood pressure, we can add new ones. It's better to add in a second drug at a low dose and keep the first drug also at a low dose, rather than to increase the first dose of the medication. So 2 agents at a lower dose is going to be better than 1 drug at a very high dose. So it's actually common for patients to need more than 1 antihypertensive to reach their target blood pressure. The TG recommends the following combinations because they are effective and complementary. So you can mix the thiazide diuretic with the ACE, ARB, or beta blocker. ACE or ARB and calcium channel blocker, beta blocker with the hydropyridine, ACE or ARB with the hydropyridine and thiazide. All these ones can be also purchased sometimes in combination packs or combination tablets, which makes it more cost effective and convenient for the patient as well. Combinations which are generally not recommended: beta blockers and verapamil-diltiazem, that can increase the risk of heart block. And then also the ACE and an ARB, basically because they almost have exactly the same mechanism of action. So it's not common that you'll see like both of them used together. You might see it on a very odd occasion. It'll always be under specialist advice. The reason being is because obviously if they work the same way, we're going to get double the risk of the side effects. So impaired renal function, hypokalemia, and hypotension. So other agents which we can use for blood pressure, but which are not first line, would be beta blockers, potassium-sparing diuretics, alpha blockers, and then the centrally acting adrenergic drugs. Beta blockers, when we're using these for hypertension, we want to have lower doses and then just titrate up as needed, not to start with very high doses. They also shouldn't be stopped suddenly because we can have rebound sympathetic effects, such as increased blood pressure and heart rate. Cardioselective agents are more selective for the beta-1 receptors, which are in the heart, rather than the beta-2 receptors, which are in the bronchi, the peripheral vasculature, and the pancreas. However, the selectivity reduces as the dose increases. So it's really, we're only going to get those benefits if we use them correctly at the lower doses. If we just continue to increase and increase, at some point we're going to get non-selective action. And so that basically negates the reason why we've selected these ones in the first place. The selective beta blockers are atenolol, metoprolol, and nebivolol. Nebivolol is one of the first-line choices in heart failure as well. The non-selective agents such as propranolol and carvedilol and labetalol non-selective, meaning they have effects of both the beta-1 and the beta-2 receptors. Trying to avoid these drugs in patients with bronchial asthma, airways obstruction, or tendency to bronchospasm is important because they are non-selective. Carvedilol and labetalol also impact on the alpha-1 reception. So that blockade of the alpha-1 receptors can cause additional vasodilation. So these two drugs are more likely to cause orthostatic hypotension. So really being aware of that in an elderly patient, especially, that have an increased falls risk. So it's very important that we watch out for that side effects. Moving on to other second-line agents, which we mentioned before. So potassium-sparing diuretics, that's the spiractin and the amiloride. Obviously being potassium sparing, we're saving up the potassium in the body, basically. So therefore, risk of hyperkalemia increases, which is quite obvious. They can be used as add-on therapy, but they're not used as first-line therapy, especially if the patients have renal disease or they're already taking an ACE inhibitor or an ARB. We need to be really careful if we're adding these agents on. Obviously, we are pushing that upper limit of the potassium, and we don't want that in the cardiac patient. We're leading high potassium, leading to like a MI. So we need to be really cautious of that. The alpha blockers, which are prazosin, and then centrally acting adrenergic agents listed there. With the prazosin, generally, we try to avoid in the elderly patients because they have a very large risk of the orthostatic hypotension and also first dose hypertension. If we're using these, it's really important that we give the first dose at night. And then be very, very aware of the patient getting up during the night. Obviously, we don't want them to fall, especially if they're already elderly. Clonidine, methyl-dopa, and moxonidine. Methyl-dopa is one of those agents that you'll see a lot in pregnancy. It's the preferred first-line agent for high blood pressure during pregnancy. Methyl-dopa can cause a bit of sedation, usually for the first few days after starting the dose, or just after increasing the dose. Clonidine can cause withdrawal symptom with rebound hypertension, so not to be stopped quickly. It needs like a tapering off, weaning. And moxonidine is contraindicated in heart failure because it's associated with increased mortality rate. So we don't want to be using that in those patients. And here's the slide, which is just talking about everything that we've mentioned there. Got your cardioselective beta blockers, the examples of the potassium-sparing diuretics, alpha blockers, and centrally acting adrenergic drugs. So in summary, controlling the blood pressure is very important, but not over controlling the blood pressure. We need that balance. Well-controlled blood pressure can significantly reduce the risk of the cardiovascular events such as heart failure, renal failure. First-line agents, we have our ACEs, the ARBs, the CCBs, and the thiazides. We need to educate the patient that a lot of the side effects, such as hypotension and dizziness, is related to what they do. So this is expected. The patient might probably feel dizzy when they first start taking these, but just educating the patient that this is common, expect that this will happen, but over time this will get better because your body will come to tolerate the medication and adjust to the new blood pressure. And then long term, it's more important that we have the blood pressure managed for like the benefit of the patient ongoing. Patients need to be aware how to manage these side effects. So especially with the dizziness, we need to educate the patient not to jump up out of bed, not to jump up out of the chair. They need to sit there, especially if they've been lying down flat for a while, or sitting on a chair quite relaxed at the back there, maybe with their legs elevated. They need to sit up first. They need to make sure that they're not getting that feeling of dizziness, that it's passing before they get up. Obviously, if they don't do that and they get up and then they fall, we have the issue of, is the patient on any other medications like blood thinners? Have they had a hit to the head? We need to start thinking about other things that can happen from this side effect of dizziness. So educating them on how to manage that before a bad event happens is the key. And that's basically it for the updated antihypertensives. So I hope you all learnt a little bit and maybe just refreshed your knowledge. And yeah.